You're listening to Transcaster Radio, a podcast about trans life and all that goes along with it. You can listen to the show anywhere you enjoy podcasts, and we'd love for you to subscribe, rate, and give a review. It helps us reach more people, and we greatly appreciate it. Now, here's your host, Kayden Taylor.
Hey Transcasters, welcome to this week's episode of Transcaster Radio. I'm your host, Kayden Taylor. I have an awesome guest for you all today, Ray Rachlin. I'm going to let her introduce herself. Hopefully I pronounced her last name properly. If I didn't, she'll correct me. Hey Ray, how are you today?
I'm really good. How are you doing?
I'm great. So tell us a little bit about yourself.
Sure. So I'm Ray Rachlin. So you're.
Oh, I said it wrong.
It's all good. Yeah, I'm a certified professional midwife and licensed midwife practicing in Philadelphia and New Jersey. I use she and they pronouns, and in my practice, I do a few things. First is that I'm a home birth midwife, so I'm helping folks give birth at home, and then I'm also helping people start their families. So I do a lot of education to LGBTQ folks on ways to start your family when you lack a piece of genetic material like sperm or eggs. And then I also do intrauterine inseminations and folks' homes, and then community education. So educating providers on trans inclusive care for both fertility and then for the childbearing year, so pregnancy, birth, postpartum. Yeah, and then I'm kind of involved in other kinds of like advocacy for trans health around Philly.
Man, you do a whole lot of stuff.
Yeah. Oh, and I'm also the president of the Pennsylvania Association of Certified Professional Midwives and a member of the Queer and Transgender Midwife Association.
Do you ever have time for yourself?
Yes, I do. Sometimes.
All right. So I have, before I'd asked you to be on the podcast, I did a little of my own background research about midwifery, but can you tell us a little bit of background of it? Because honestly, before that, I didn't know much about it.
Yeah, midwives are like this really interesting old secret. Like we're the world's oldest profession and also are in a unique spot where we're serving a lot of queer and trans people. So yeah, it's kind of an interesting niche. It's so historically we've been the folks that have delivered babies and cared for pregnant people and people who are like in the early postpartum, so like nursing babies and healing from giving birth. And as our profession has expanded, we've also included care throughout like the reproductive lifespan, primarily for people with uteruses. And, for queer people, the childbearing year starts at preconception, so before you get pregnant. So that's something that has become really a passion of mine and also part of my scope. But we're doing this reproductive care from a different philosophy than an obstetrician does, where, we are more grounded in like caring for like the social, physical, and emotional aspects of reproductive health, and working with folks that while treating them as the expert on their own body and their own health, and working more in partnership. So it's a different kind of like power dynamic in providing care.
Of course, yes.
And there are midwives that work in hospital settings and midwives that work in clinics, some that do birth center birth, so where you go to a freestanding location to give birth, and then folks like myself that help you give birth in your living room.
Awesome. When I've always thought about births, I always think of, traditional, what is nowadays that they go to the hospital to give birth. So, but, personally, I'll never be pregnant, but my, fiance and I have talked about having children, and we might someday. So, and, I know that, for me, the hospital is such a stale, environment. And I know that there's reasons why it is and they have to be, but I would think giving birth at home would be just, I guess the experience overall, I feel like would be more inviting.
Yeah, I think it's definitely more comfortable for some people. Others feel more comfortable in a hospital setting, and that's like the right place for them to birth. But what we're seeing like in the trans community specifically is that like a little bit of data we have on trans people who are using their bodies to give birth is like really, really, really high use of midwives. So like 45 to 50% of them are using midwives, and 20% are having out of hospital or so home births or birth center births. And compared to the general population, about 9% of people are using midwives, and like 1.36% are having out of hospital births. So there's like elements in like the model of care that midwives offer that's like really speaking to like what trans people need when being pregnant and giving birth. And also, you know, like like our model like of being home like allows you to just like know who your provider is versus like having unknown providers or multiple providers during childbirth. And so like kind of you're able to like protect yourself better from discrimination when you have a known provider who knows your pronouns, who knows your parenting terms, who like uses appropriate language for like, you know, your junk.
Yeah.
Yeah, through the birth
Do you think
process.
that that's why trans people are apt more to go with a midwife?
I think it has partly to do with philosophy. I think it's partly fear of discrimination in the ways that home birth allows that to protect yourself on that. It could partially be cost. If you're uninsured, a home birth is definitely cheaper than a hospital birth. If you have insurance, a hospital birth is generally cheaper than a home birth. But I think it also has to do with just the way that like queer theory and like the way that like we as queer people like view our bodies and like looking towards like, you know, like self-determination, you know, having like really full information about tests and procedures, you know, having time to include partners in care, these aspects of like how we want to be treated as queer people are also like modeled in midwifery care. And then like when you're in a smaller practice like mine, you know, I have the flexibility to just like, you know, like my waiting room is gender neutral. I have gender neutral bathrooms. There's like no, like the only paperwork that you might interact with it that is gendered, that's electronic, like I can tell you about beforehand and give options to not do. So there's ways that like smaller practices can like meet some of the like, you know, trans inclusive benchmarks easier than a larger hospital setting that has to do like a major policy change to change one form.
Okay. Yeah, that makes sense.
Yeah.
What kind of schooling do you need to become a midwife?
So there's a couple of different kinds of midwives in the US. So I'm a certified professional midwife. And for that, I went to school on the West Coast for 3 years and did 2 years of clinical training at a birth center, doing birth center and home birth care. Certified professional midwives like myself train exclusively with out of hospital birth. Some go to 3-year programs like I did. Others will train through apprenticeship and like a lot of self-study and a lot of exams. And then there are also certified nurse midwives, and those are folks that are nurses first, and then will get an advanced nursing degree in midwifery. And they typically will do their training in a hospital setting, and the majority work in hospitals, but some also do birth center or home birth.
Okay. What made you decide your route?
I think I started off as a doula in New York City, and I was going to a lot of really violent births in the hospital as a doula. So as a trained support person, that's what a doula is, like a trained coach. And, you know, as that role, I'm like not a medical provider. I don't have power. And I just was like watching people not be treated well. And I really found that the way I wanted to become a midwife, I wanted to train outside of that system. I wanted to not be under residents who, you know, could take power away at any time. I wanted there not to be like as much fear in my training and just to train with normal birth and to train independently. And I knew I wanted to do home birth. The first home birth I went to, it was like this like light bulb turned on. It was like, oh, I need to do that. So yeah, that's kind of, I don't know. I did a lot of research on all the different pathways because it's super confusing.
Yeah.
And then I chose my path, and like 2 months in, I was like, oh, I didn't understand this at all. But it's a good fit for me. I'm, you know, CPMs, we tend to work alone and practice independently, and I really like that because I can just have a practice that's like centered around the needs of queer and trans people.
Yeah, that's what I was curious. So you don't have to have a medical provider like a doctor or a DO or anything like that to have your own practice?
No.
Okay. Right.
There are states that you have to have like more supervision.
Okay.
I have a backup physician in New Jersey, but that's about it.
Okay. All right. With trans people, have you altered any of your verbiage when you're discussing pregnancy with them in your, because pregnancy is so drastically been held as something that only females do. And especially with trans men who still have a uterus and choose to get pregnant, do you feel that you need to alter your verbiage at all and when you're talking about it to them?
Yeah, I've found that if I use gender neutral language with all of my clients, so including my cisgender heterosexual clients, then I don't need to change my language. And I think, pregnancy and birth are incredibly gendered in our society. And
Yeah.
I think the binary of like gender and motherhood, like, isn't good for straight people either. I think a lot of people don't fit into that mold and that binary. And scaling back my language and using trans inclusive, terms when I talk about pregnancy and birth and infant feeding is going to benefit everyone. So that's what I do. With trans clients, the things that I do differently is, asking, and queer clients too, like asking what terms they use for their body parts and, what terms they are comfortable with me using, during care and during labor. So things like, that might be called in the hospital a vaginal exam where you're measuring the dilation of the cervix, like what language would be comfortable? Can I call it a cervical exam? A junk check, like, yeah, like just mirroring language and being, yeah, having that like prominent in my chart so I can use language that feels comfortable and affirming.
Okay.
I spend more time working on helping create networks of support and resources because the resources are typically gendered. The support groups are gendered,
Yeah.
and really focus on motherhood. So trying to, and I found a loss, at that when it came to, working in Philly. So I just created my own. Like every other month, I host a free potluck for anyone who's trying to conceive, pregnant, has a baby, and wants to meet other queer and trans people. And
Oh, that's great.
that's been, yeah, because there was just like wasn't anywhere I could refer people. So like, okay, well, we'll just create the alternative. The other thing I do differently with trans folks is I have a more solid transfer plan in the event of going to the hospital. And so I work with an amazing family medicine doctor who does a lot of trans care at Pennsylvania Hospital, who was like able to get approval from her department to do continuity of care for home birth. So that what that looks like is my clients will see her like once or twice during the course of their pregnancy. And then if there was a reason to transfer to the hospital in labor, I can transfer to a known provider and like I'll provide her records, usually around 36, 37 weeks of pregnancy. The due date is 40 weeks, by the way. So that's like the beginning of when they could go into labor. And so she does advocacy like on the labor floor about like, these are this person's parenting terms. This is the language they want to use. This is just like all of going down the list of like how we can provide the most affirming birth experience if there's a reason to transport from home. And then the two times that I've transferred to her, like she comes in, like she's not working and she comes in and like provides complete continuity for my client. So
Oh, that's
she's like
awesome.
such an advocate and ally, and then allows me to provide really good care to trans people because so much of like the like risk is in unknown providers.
Yeah, exactly. That would be a concern of my own as a trans person, that if I were in that situation and I could not finish the birth or something happened after the birth and had to be taken to the hospital, what, how am I going to be perceived at, the hospital? Because I have had some not so wonderful experiences having to go to the hospital in an emergency due to female parts, and it's I think that's great. I mean, if other people out there could get that same, get an ally or another practitioner involved in that situation, that you would have to transfer it, I think that would be great, especially in such a being pregnancy such a important topic for trans people, because it because pregnancy, like we talked about, is such a, in society is so female oriented that they don't think about it any other way, that a man could get pregnant. So I think that's great. And that kind of goes into my next question for you. As a healthcare provider yourself, what kind of recommendations can you give to other healthcare providers or even trans people as ways their provider can provide a safe and affirming space for their patients?
So I think, let's see. I think probably the first part is, like having the like trans 101 competency. I go to the Philly Trans Wellness Conference every year, and there's a whole slew of providers that just need to learn how to like use people's pronouns, and like that's step one. Like this is
Yeah.
how we respect the person in front of us. It's takes some practice, but you can do it. And then the next step is like, how do you provide the affirming care? And I think it, for people that have done it for a few years, it's hard because there's not great research. And so, when it comes to, the childbearing year, which is like where my expertise lies, typically trans people have been told that they will become infertile if they use hormones. And that's not, it decreases fertility, but trans men have gotten pregnant while on testosterone. Trans women have created pregnancies like while on estrogen. It's not impossible. And also, like what we're starting to see in community is that people's fertility is returning when they get off hormones. We don't know how much, like we don't have the data to explore that, but I think people have been given like advice based on fear and like based on inference and not actual based on like what we're seeing in community. And so I think as a provider, I find it so instrumental to be like actively like working and studying with other healthcare providers to find out like what other providers or experiences are and building community knowledge about like, this is where, the medical literature is right now. And then this is what we're actually seeing, like trans people can have healthy bodies, healthy pregnancies, like healthy lives. And like, we are doing the best we can to find like the tools to support that while medical literature catches up.
Yeah. 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 I think that's important.
Yeah.
I have not been to the Philly Trans Conference. I plan on going next year. Unfortunately, I'm moving the weekend of the conference this year, so I'm not able to go, but I definitely want to go. And I think if we can do anything, I think, getting together and collaborating together is the right way to go. So,
Absolutely.
um, do you take insurance at all, or do midwives typically take insurance?
It depends on the state. So certified professional midwives are typically very poorly covered by insurance. Um,
I figured.
I'm out of network, which means if people have certain kinds of benefits, part of my services are covered, and then because we're poorly covered, myself and other folks will do things like, doing a discount for anyone who's on Medicaid, doing varieties of bartering. I do a few pro bono births a year. So like find ways to like match my values with some of the limitations that capitalism and, the medical industrial complex put on.
Yeah.
Nurse midwives tend to be better covered by insurance.
Why is that?
So they're more integrated into the healthcare system. They train in the hospital system.
Okay.
They're better integrated. So, if you're going to a hospital-based midwifery practice, most likely it would be well covered. More of them are able to take Medicaid. Certified professional midwives can take Medicaid in like 13 states. So yeah, can be more affordability for either hospital-based midwifery care or some birth center or home birth for them.
Okay.
But like in states like Florida actually has amazing coverage for midwives.
Okay.
And then like the West Coast, like Oregon, Washington, California has really good coverage. Parts of the Midwest like Wisconsin, and then like the Northeast, like Maine, Vermont, New Hampshire are really well covered, and everywhere else is like a hodgepodge.
Gotcha. Okay. Yeah, I wasn't sure about that, and I was curious if you'd think it's been around forever. You would think that that you all would be covered in insurance, but that's insurance in America. So,
yeah.
So talk to us a little bit about the difference between having a home birth and giving birth at the hospital.
Yeah. So when someone plans to home birth, they're typically working with one midwife or maybe a small group of midwives, like 3 providers. And most of the time, your appointments are an hour long. And so over the course of prenatal care, so you have like there's like a schedule of visits that are outlined for how to do prenatal care. Like usually you're seeing someone monthly until the 3rd trimester, and then every 2 weeks until 36 weeks, and then weekly until you meet your baby. Like in a home birth setting, the appointments are typically like an hour. So you have a lot of time to like have your questions answered, talk about tests and procedures that are available, catch up on what's going on in your life, you get to know the midwives and they get to know you. And then when it comes, are more responsible for your care. You have to get supplies to, keep your home clean and, prepare for having a baby in your home within hours after birth and how you're going to care for them. So there's definitely like more work on the pregnant person's part. And then when you go into labor, you're like, folks are like, when I'm their midwife, in touch with me by phone in the beginning. And then once they're in active labor, so the time that they're having strong regular contractions, I come to your home and stay. And so, we monitor the baby during labor with using a tool called the Doppler. And we're also taking the pregnant person's vitals and helping them, move and eat and drink and pee and monitoring for safety. And but the person has freedom to eat what they want and to wear what they want and to move how they want and give birth wherever and however they want. And it's a way that, if like a partner wants to catch, it's super simple to help them do that. If, the birth parent wants to catch, we help them catch their own baby. And then there's a lot of things that are advocated for in the hospital, like having the baby on your chest right after birth and not cutting the cord. So, interventions that can affect bonding are just really routine in home birth. And typically a midwife will stay for about 3 hours after birth to like help the parent and the baby become stable. And if they're choosing to feed at the nipple, to establish chest feeding. And then I'll tuck people into bed around 3 hours and then I come back to check on them at like 1 day and 3 days and then 7 days and 2 weeks and then 4 and 6 weeks. So there's less time being monitored right after, like in the day after birth, but more postpartum care.
Okay.
When you give birth in a hospital setting, you're typically in a group practice. So there are some providers that work individually or with, 3 people in a practice, but most are larger groups. So most of the time you have 15-minute appointments. You may see the same provider or different providers at each appointment, but you won't know who the person on your birth will be. I do think one of the ways that hospital practices can advocate for trans people is to like alter the call schedule so they can have a known provider at the birth. But typically what happens is when you go into labor, you call the triage line and you're in touch with the kind of nurse or provider who's on triage, and they'll recommend when you come to the hospital. And when you get there, you're greeted by a nurse, and sometimes there's also a resident, and you would they would do the monitoring that we do at home, like in the room. And so using either a Doppler, but more likely belly bands, so putting 2 bands around the stomach to monitor the baby. It's routine to start an IV, and the labor kind of unfolds in that room. And there's more tools available. So, there's things like Pitocin, which can make contractions stronger, and there's pain medication like epidurals, which is not available at home, and also ready access to a C-section. And also some trans people will choose to have a planned C-section because they want absolutely nothing coming out of their front hole. And that's also an option. And when you give birth in a hospital, there's typically about 3 people in the room, and you're in the room that you give birth in for about 2 hours. If you have a C-section, you go to a recovery area afterwards, and then you're in a hospital birth, you typically stay 1 to 2 nights, and at the C-section, you stay 2 to 4 nights in the hospital afterwards, recovering, and then are discharged home. The baby has the follow-up appointments at the pediatrician, and then the birth parent is not seen until 6 weeks.
Wow. Okay.
Yeah.
Yeah, that's a long time. That's even for a C-section?
Yeah.
Wow. Interesting. Yeah, I didn't realize it was that far after.
Yeah.
Okay. What we touched a little bit about this, but what kind of impact, if any, does hormone therapy have on fertility?
So we don't know is the first answer. I think it's historically, been advised that, someone starts hormone therapy to assume that they're infertile forever. However, I mean, what I'm seeing in my practice, and I think what other providers are seeing in their practices, is that when people go off hormones, fertility is returning. So in the largest study on trans birth, Light et al., the average time for the trans men or genderqueer people in the study who would get their periods after stopping testosterone was about 4 months. And so once someone got their period again, it's assumed that they went back to their like natal or their hormone cycling that they had before they started hormones. And the same goes for sperm. So it takes about 90 days for sperm to grow and recreate themselves. So typically about 3 months of time off estrogen and spirulactone would be enough time for kind of their natal hormones to come back and revive spermatogenesis, so the creation of sperm. And that's like something that typically when people are doing this, like we'll just go off hormones and then see when they get their cycle back. I help people with herbs to try and get their cycle back quicker, or start, shed the estrogen and the spira out of their system quicker. Because typically, the time where you're like trying to get pregnant but have just gone off hormones and are not like actively having a baby growing is like the most stressful time. So we try and do everything we can to minimize that. But also, I also want to mention, sorry.
It's okay.
That, some people in our society will have infertility, and I believe also some trans people will have infertility, and we don't know what was happening in your body before starting hormones. So like that's also a potential, but people typically don't know that they're infertile until they're trying for a little while to stop. But we don't have any evidence that trans people are experiencing infertility or that it's linked to hormone use.
Okay. Have you ever had, whether or not it be a trans man or a trans woman, get pregnant or get somebody pregnant while on hormones?
I have not had that in my own practice, but I do know of cases where that's happened.
Okay. Because I know a lot of people will say, well, I don't need to use protection if they're having intercourse. And because I can't get pregnant. Of course, you want to use protection for other things, but a lot of people will say I don't need to use it. So I was just curious if you had ever heard of that happening or not.
It definitely does. So there's a really amazing Facebook group called Birthing and Breast or Chest Feeding Trans People and Allies. That is like the largest collection of like trans people who are like using their bodies to make babies like anywhere in the world.
Oh.
And, every few weeks there's a post about that. And we also saw Light et al. Is the largest study on trans people who've given birth. And a quarter of those pregnancies were unplanned. So which correlates with, in the US, like of cis women, like half of pregnancies were unplanned. So less, but still like a really good percentage.
Yeah, it's still happening.
It's definitely happening.
Yeah. As a community, how do you think we can promote more understanding and acceptance of pregnancy in the trans community? Because I think, especially the cisgendered community looks at trans people as, we shouldn't be procreating. And so how can we, I think it's a lot of it has to do with ignorance and the fact that they don't understand it. And there's still not a lot of acceptance and as far as the trans community as a whole. So how do you think we can help promote that for us?
I think we need to continue to break down the gender binary that pregnancy is something that women do. I don't think it serves anybody. And as we do that, we also need to create our own resources, because right now resources for creating a baby, growing a baby, having a baby, like new baby life culture are so gendered and we are just left out. So creating our own spaces, creating our own, like a lot of that's happening online, because people are far apart from each other, but also creating like resources in every community to like share and develop our unique family narratives of like, because trans people are like using their bodies to like create pregnancies and have healthy babies, and we just need to like create more connection with each other and like grow our community resources and support for that, because it's going to continue to happen.
Yeah, I agree completely.
Yeah.
I think it's important. Um, and although as a trans person myself, I personally wouldn't get pregnant for many reasons. But I think it's important that it's okay for us to get pregnant and have babies and have families and live a normal, in quotation marks, normal existence. So I do think that's important. Um,
Yeah.
how in your practice do you promote chest feeding without causing dysphoria? Because I personally, that would have caused me dysphoria um, if I had been going through that prior to top surgery. So how do you promote that? Because obviously we know that it's a good thing for the baby, but you certainly don't want to cause dysphoria to a trans person who the pregnancy alone could cause dysphoria.
Right. So first and foremost, like I ask open-ended questions about how they're planning on feeding their baby. Are they interested in feeding their baby at the nipple? What language do they use for their chest? How do they feel in relation to their chest? And what are things that they might need to, yeah, if they're wanting to feed their baby on the chest or at the nipple, like, yeah, like how could we create like emotional support around that if there's dysphoria in that area? And the majority of like trans and non-binary pregnant people I've worked with like have chosen to chest feed. And like we've talked a lot about fashion, which is usually like muscle tanks and like large button downs that are open, and just ways to like have a more masculinized chest at a time that you like can't bind or compress. um yeah, what kind of early times of like breast and chest feeding are like versus kind of when a baby's a little bit older. And also creating space for like if they need to not do it, and that like promoting their parent, like their well-being and their ability to parent is more important than breast milk or human milk.
Yeah.
And for the trans folks I've worked with that choose not to, we just talk about suppression. So both milk suppression, so either like some people who've had top surgery like can chest feed, and like you just don't know how much milk you'll have until after the fact.
Oh, okay.
The major like if you're having double incision with nipple grafts, that's going to take out the most glandular tissue, but there's probably still a little bit left. If you have keyhole, there's going to be a lot more glandular tissue left, so that just kind of depends on how much tissue is left and then what happens in pregnancy before you know if you could chest feed with your own milk or you could feed at the nipple with somebody else's milk, like using a supplemental nursing system. So we kind of go through all of the options. And if they're like, nope, not going to happen, I'm like, great, this is how we're going to suppress your milk. If they want to experiment, we talk about how to like, experiment kind of in the early days. And a lot of laying a milk supply happens in the beginning. And yeah, I would just kind of keep checking in regularly. And I do a lot of postpartum care. So we kind of have the opportunity to like make a plan and then reevaluate and change the plan if we need to.
I'm curious, can a trans person chest feed and be on hormones again?
So there's one person in medical literature who went on low dose T, and they studied his milk, and it did not transmit through the milk. It will suppress the milk supply though. So if it's more about like the emotional bond, then yes, probably, but the T might go to the baby, and we don't know what effect hormones will have on a baby.
Okay.
But we have one piece of evidence that like one person that it didn't. Um, so if it's more about bonding, then yes, maybe. And if it's more about providing sustenance, then delaying is better.
Okay.
And also, I will say trans women have successfully induced lactation to feed their babies with their body. So it's something that like cis adoptive mothers have been doing for years of like inducing lactation.
Oh,
And
okay.
you can take 2 medications, domperidone, and then adding a combined birth control pill to estrogen therapy to mimic pregnancy, and then starting to pump about 6 weeks before birth.
Wow.
And so trans women can also use their bodies to like feed their babies, or any other partner can like a cis woman partner or trans or non-binary partner can also induce lactation on their body, or use like a small tube that goes into a bottle to feed the baby at the nipple without taking any medications to induce lactation.
Oh, okay. I didn't realize that. That's
Yeah.
interesting.
Lots of options.
Yeah, definitely. What advice do you have for a trans or non-binary individual or couple who's seeking to start a family?
That's a really good question. I think I love birthing and chest feeding trans people and ally Facebook group. I think it is like such a wealth of resources. In a lot of cities, there are now like queer midwives like myself who are creating services for our communities. So like in Oakland, there's like a trans and gender non-binary like trying to conceive group. Family Equity Council does a lot of education throughout the country and is like a really good resource for our community. There's midwives in the Midwest and California and in New York who are like creating content and creating services that are like geared towards us. And also there are fertility clinics as well that are like marketing and trying to work with trans and non-binary folks to like help them start families. And many queer people also use fertility clinics as a way to like start their family as well. But I think it's, it's hard to like, if you're like doing research to like find resources that reflect our language. So as much as, we can like, okay, what is the information we need? And like, what are the, sources we can tolerate getting it from can be a bit challenging, but the information's out there and we're trying to like grow in like, in like numbers and resources. I know I just started a blog called Queer Conception Stories just because I wanted to create another avenue that you can learn how other people got pregnant, and just it's queer people writing their story of how they conceived a baby. And sometimes, and the stories I have up so far are also just pregnancy and birth as well. Just like, how do we, like the information is out there and we're trying, like people like myself are trying to like find ways to get it into community. But sometimes it takes a little bit of work to get connected to it.
Awesome. I will post a link to that for this episode.
Yeah,
definitely. And also to the Facebook. Is that Facebook group closed or open? Do you know?
You have to apply to be on it
All
and
right.
answer questions. It's also open to allies, but there's a lot of like questions about like, are you an ally? Great. Like, do you know how to shut up? And it's like, yes, great.
Okay. Important questions.
Really important. Yeah.
Important questions. All right. Well, I appreciate it that you took the time out today to talk to me and the listeners. And I hope that maybe we can have you back on again at a later date. So
yeah, I'd love to. Thanks for having me on.
All right. Awesome. All right, Transcasters, that's all we have for you this week. Thank you for listening, as always, to this week's episode of Transcaster Radio. Don't forget to tune in next week for another great episode. Until next time, love life, live authentically, and as always, rise up.
Thank you for listening to Transcaster Radio. Be sure to visit transcasterradio.com to access the show notes and discover awesome bonus content.